Good morning, everyone. Good morning. It's great to have everyone here. We're going to give just a minute to have everyone sign in. My name is Maura Little. I am the Executive Director of Cambia Grove, and we are thrilled to have so many people joining us for our annual 5 Points Conference. We're going to give just another 30 seconds as everyone signs into the Zoom webinar. Please note that today's event is being recorded. And as you sign in, please do take a look at all of the functions below. We will be taking Q&A or gathering questions through the Q&A channel throughout the conversation. We'll be asking those questions from the audience at the end of today's event. All right, let's go ahead and get started. Welcome everyone, and thank you for joining us today for our annual 5 Points of Healthcare Conference. My name is Maura Little, and I'm the Executive Director of Cambia Grove. Cambia Grove is a healthcare innovation hub. Our role is to work with partners in the community to enable impactful innovation to succeed. Since our organization was founded 5 years ago by Cambia Health Solutions, our methodology has not changed. We convene stakeholders, we identify barriers, and we catalyze solutions. Today, as we convene for our annual conference, I would like to take just a moment to condemn the violent acts against our democracy that took place yesterday at our nation's capital, as well as many state capitals across the country. These were not singular acts, but acts that have built up over many years as our country grapples with the foundation of our democracy. The United States is built on the ability for people who disagree to come together peacefully, listen to one another respectfully, and work together honorably to solve some of our greatest challenges. Today, as we come together as a healthcare community, I hope that you will truly take a moment to listen respectfully to one another, not just for what we agree on, but what sets us apart. This conference seeks to bring a real, honest, and direct conversation to the forefront of healthcare transformation. This is not an easy conversation, and I truly would like to thank each and every panelist for joining us today. Thank you. In the spirit of listening, you will not see any activity on our Cambia Grove social media platforms, as I have asked my staff to pause our social media platforms during today's discussion. We are doing this to ensure that we as a staff, as a team, are truly listening to one another, truly listening to the panelists, as well as truly listening to the questions that are coming from you about the context of this discussion, not just sound bites that we can fit together into a tweet. I invite you to pause your social media as well. While we won't be on social media, as I mentioned before, I do encourage you to ask questions throughout the conversation. I will be monitoring the Q&A box at the bottom of the screen and will ask your questions at the end of today's discussion. And so, in the spirit of this community of health innovators, we look to each other today even more so. It is our belief that healthcare and those seeking to improve its positive impacts for patients are uniquely positioned to address many of the challenges facing our world today. Thank you all for joining us. Thank you to the panel for joining us. It is now my pleasure to welcome our incredible moderator to the stage, Christine Monkhouse. Christine?
Thank you so much for having me, Maura. Can you hear me? Can you see me?
You're great.
Wonderful. Hi, everyone. My name is Christine Monkhouse. I am the founder and CEO of Patient Orator. Today, I'd like to say that humanizing healthcare is a necessity for me as a patient in being Black and also being a woman. I am a human being, but oftentimes my interaction, not only with mainstream society, but also with our healthcare system, I am made to believe that my voice has no value because of the color of my skin and or my ethnicity and sex. In my interactions with healthcare systems as a patient, I want that my healthcare issues are resolved quickly, safely, and in the most efficient way. But most importantly, as a Black woman, I want to be treated as a human being. In short, I want to be treated equally as my white counterparts to live a full potential life and have a full life expectancy. The facts are that 40% of second year med students believe that African Americans or Blacks have thicker skin than whites. That 22% that African Americans are prescribed a prescription pain medication at 22% less than their white counterparts. And when asked if the medical industry discriminates against women, 91% of women stated that that has been their experience. In my patient journey, it has taken 3 years for me to be prescribed prescription pain medication to manage my pain. I was delayed treatment. I was undertreated. And for each year that this happened, I suffered tremendously from the impact of silos that exist in our healthcare industry, where my medical information did not pass from one system to another. I was delayed care. The lack of interoperability almost cost me my life. And perhaps if the healthcare system that I've been interacting with had been communicating with each other, my pain issues would have been prevented. It had taken me 6 doctors and multiple run-ins with the health system for the seventh doctor to finally listen to me with compassion and kindness. She exemplified humanism, like I like to say, in its purest form. In a moment where I was most sickened with the worst pain in my life, I was finally met with someone who treated me with empathy, with dignity, who would look past the color of my skin and hear the tiredness in my voice. This was a doctor who chose to practice medicine in a humanized way because she made me feel like a human being. But by then I had to endure painful pain injection therapy to live pain-free, but only temporarily. There are no words to describe the physical pain that I've endured as a patient, but perhaps the most damaging pain of it all is the psychological impact that I've experienced in the encounters that I've had with the healthcare system. I've learned to not tolerate insultive tones, so to speak, and our stereotypes that negatively impact my experience as a patient, to prioritize my voice and have it be valued in the healthcare encounters that I have. And lastly, I was inspired by my own journey in not being heard to create a solution that will empower the voices of patients, specifically underrepresented patients, so that they can document changes within their health and that their voices can be empowered in their interaction. And most importantly, they can access the resources that they need to have a better health outcome. My message today is that when racism, ageism, genderism, sexism, classism exists in a health system, it literally kills patients. Long-standing inequities, racial biases, mistreatment of people that look like me should not be tolerated by the healthcare industry. As a patient, I am on the receiving end of healthcare, and I am one of the 5 Ps. The rest of the Ps, namely providers, purchasers, policymakers, and payers, play an integral part in my story and the stories of all patients. Today, I have the privilege of introducing the remaining 4 stakeholders, namely Dr. Juan of Evergreen Health System. Dr. Juan, please welcome to the stage. Please introduce yourself, who you are. Please provide a one-on-one role of your background and your organization. And please provide the role that you play to help improve experiences for patients.
Yes. Thank you, Kristen, for the introduction and that deep reflection about your experiences. Also, thank you to Kinda Grove for the invitation, and to Mara for the deep reflection of the historic events, unfortunate historic events that our country is undergoing. Certainly deeply impactful for all of us, and a moment of reflection for our country, and hopefully for change as well. As Kristen said, my name is Juan Aragon. I'm a physician by background, practiced for about 10 years, and now are the Director of Business Development for Evergreen Health in Kirkland, Washington. We're a 2-hospital system with full scope of services from primary care and prevention and community work, all the way to home care, hospice, and a research platform. Our system is located in one of the most beautiful, more diverse areas of the country. We have a high degree of people coming in and out of the area because the businesses and technological development that we have. So it's a beautiful and exciting place to live. I've been with the organization for about 10 years and scoping roles of developing and growing the medical group, the care processes, the clinical processes. And now my sole focus in the organization is to help grow the system by creating innovative partnerships, introducing innovative ideas and different care models. A good example of the work that I do and how the health system, or I help the health system and the provider center system, is some of the work that I'm doing today in helping figure out or establish what the role of the health system is going to be as we battle the substance use epidemic in our community, because certainly has been accelerated by the COVID pandemic. Before the pandemic, we certainly had this problem in the community. We had lack of providers that were trained, lack of training for the staff to be able to treat these patients with compassion and care. Lack of resources to treat these patients holistically is certainly a problem that extends beyond all of us. And what I'm doing right now is figuring out what role does the health system play, and how can we partner creatively with innovators, startups, entrepreneurs, other health systems, payers, and policymakers to make sure that we are able to care for those patients appropriately. In my prior work as part of the Director of Clinic Operations and Research, I did something similar by creating policies and processes that ensure that our staff care for patients deeply in the same way that they would love to care for their loved ones, that we had the right processes to care for the patients at the right time and develop new solutions that weren't available to our patients through our research and clinical trials department. I'm really excited to be here, and I'm looking forward to participating with the rest of the panelists and the Q&A section.
Thank you so much for being here, Dr. Juan, and representing the provider's voice. Now I'd like to welcome Dr. Marion Couch. She is the Chief Medical Officer at Cambia Health System. Dr. Couch, please welcome yourself. Please tell us who you are, your background, your organization. What role do you play in providing healthcare to patients?
Thank you, and thanks for allowing me to be part of this panel. Look forward to the discussion. I'm Chief Medical Officer of Cambia Health Solutions, which is a company in the Pacific Northwest that administers Blue Cross Blue Shield plans in Oregon, Washington, Idaho, and Utah. In addition, they have a number of wholly owned companies, such as Journey, and which is a digital health solutions company, and then also have a venture capital arm in conjunction with North Carolina Blue Cross Blue Shield called ECHO. I'm also the Senior Vice President of Healthcare Services at Cambia and have about 800 people who report up through me for clinical services, network management, provider engagement, pharmacy, program integrity, and a number of other teams. My background is one of a provider. I began as a trained otolaryngologist, head and neck surgeon, and I say trained because I haven't operated in 2 years. But my evolution has been that I was in academic health systems, and was also involved in medical groups. I was a vice president of finance in a medical group, and then was the surgical executive physician in a large medical group. I was also chairman of 2 surgical departments, and then became chairman of a large medical group board. About 2.5 years ago, I had the opportunity to go to Washington, where I served as the senior medical advisor in the Office of the Administrator at the Centers for Medicare Medicaid Services, which I'll refer to as CMS. And that is a large purchaser of healthcare, covers about 145 million Americans, has a $1.3 trillion annual budget. And in my role, I was able to have a cross-cutting leadership responsibility across Medicare, Medicaid, the Innovation Center for Payment Models, and was really enjoying learning about the regulatory and government part of healthcare. And then the pandemic hit. And so was immediately involved in things such as the vast expansion of telehealth, hospitals without walls, a number of innovative solutions that are still ongoing to address the pandemic. Approximately 4 months ago, I then took a job at Cambia. And I would say to you why I'm trying to make sure I cross and learn about healthcare from many different perspectives. What excites me about this role and about healthcare in general is that we're at a moment of enormous transformation, unlike anything I've seen in my 30 years in this business. We're seeing a new normal come out with telehealth and a lot of innovations of care where we have providers, patients, and payers willing to have new solutions come to the front and adopt them. We're seeing a blurring of provider and payer roles. And I think in the middle of that overlap is where magic can happen and where we can have true solutions develop. And I look forward to think about better ways to partner with providers because they hold the pen. And I think that when you're working in conjunction with providers, who I think have a terribly difficult role, you're going to be able to serve your members and your patients in the best way. So I'll stop there. But again, thank you for inviting me to this panel.
Thank you so much for being here and representing the payer's voice. I'd like to now welcome Lauren Villa. She is the Senior Director of Member Value, Pacific Business Group of Health. Welcome to the stage.
Thank you. Thanks for including me in your panel. And then thanks for your interest in hearing more about what purchasers think about healthcare. So I am with the Pacific Business Group on Health, PBGH. We are a 501c3. And we are a membership organization. Our members are very large purchasers of healthcare. So both public and private purchasers, folks like Walmart and Disney and Comcast, at Boeing and Microsoft and Costco, in fact, in your neighborhood, but also public purchasers like CalPERS in the state of Washington, covered California. And we, those organizations support us because they spend a lot on healthcare. They are ultimately the purchasers of healthcare for all Americans who are accessing healthcare through their employer-sponsored insurance plans. So PBGH is a 501c3 I mentioned. Our mission is to address the affordability and the quality of healthcare by really promoting and supporting the move to more value-based systems. Payment reform is an important cornerstone of our work. We have a few levers that we pull in our effort to move the progress of healthcare. First is that we have a strong policy arm. We think it's important in order to have functional markets that we address some of the dysfunction that exists in the way policy is orchestrated. So we do spend a good amount of time in Washington influencing and educating and advocating for the purchaser's voice amongst policymakers. We also have a care redesign team. So we actually go into the healthcare system, working with doctors, working with medical groups. This work is highly California-centric right now, but really identifying opportunities to redesign the way care is delivered, especially in the area of primary care, but also addressing areas like specialty medicines and things along those lines. And third, of course, is our membership arm, which is a lot of purchasing power. Our members collectively spend about $15 billion on healthcare in this country, representing 10 million covered lives. So we are we know that the purchaser, with their mighty purchasing pen, has the capacity to make change in the way we pay for and the way we deliver healthcare. All of that sits on a platform of measurement and accountability. We have a team working, pushing the needle constantly. We've been on virtually every measurement body in this country. We know that we must have transparency, we must have measurement, we must have transparency. And we're now pushing the envelope on patient-reported outcomes, because we know what's really important is how patients are reacting to treatments and the experience of the patient. So I look forward to the conversation today, and I look forward to sharing the purchaser's point of view. Thank you.
Thank you so much for being here, Lauren, and for sharing the purchaser's point of view with us. I'd now like to welcome to the stage Megan Hawk, a partner at Nathan & Hawk. Welcome to the stage. Introduce yourself, tell us who you are and the role you play in healthcare.
Thanks, Christine. I'm happy to be here. I appreciate being part of this conversation. Thank you, Maura, for your words at the beginning. I am here in Washington, D.C. with a view of the Capitol Dome outside my window, and it has been a particularly difficult 24 hours for the nation, but certainly here. And so I really appreciate this conversation, because I think it's important, as Maura said at the beginning, to really listen to one another. I think we do a lot of talking while waiting for our next turn to talk, instead of listening to what someone else is saying. So thank you for creating this forum. I have spent the last, which is insane for me to realize now, but 25 years in Washington. The first big part of it as a congressional staffer working in the Senate. And I know that you all deal with your elected officials on every level, from the local government, state government, and federal government. I am most familiar with the federal government. I worked on the Senate Budget Committee and for Majority Leader Mitch McConnell. I did spend 3 years in the Bush administration at the Department of Health and Human Services, and then at the White House doing what we call legislative affairs, as sort of a liaison between the House, Senate, and White House. I have a former boss who called Leg Affairs the ambulatory bridge across a constitutional divide. So just trying to help everybody figure out why the other person is doing what they're doing. And then left the Hill about 10 years ago now, and started my own firm, Nathanson and Houck, with Melanie Nathanson. And we're a bipartisan lobbying and strategic consulting firm. And so, you know, a lot of what we do is really help people navigate this complex system and figure out, how do we influence it? How do I get my members of Congress to hear me and really hear my story? And I think it's really important, you know, for the work that Lauren is doing and the work that Marion is doing, for people to understand that Congress and the administration respond so much better to, here is what we're doing, let me show you how it worked. They're not the experts on most of these issues, and so expecting solutions to come from Congress is probably not the most successful way to go. And I think what does really bear out is real world experience, where whether they're providers, whether they're patients, whether they're you know, payers and purchasers and insurers, to be able to say, we're trying to figure out how to achieve what we all want to achieve. This is one thing we did. It worked for us. It could work for somebody else. I think that's a really important conversation to have. I also think, and you know, this obviously probably has a little bit more meaning today than it would have 2 days ago. I think people see only the headlines of things that happen here in Washington. And I think it's important to note that thousands of pages of regulations come out of Marion's old office or other departments all around DC, and that's another opportunity to really influence the way that the administration and government is thinking about the healthcare space. We do a lot here. It doesn't feel like it right now, but it will when we get back to normal. We do a lot here, and there are a lot of bills and legislation and policies that pass that don't get the New York Times headline. But I think it's important to remain engaged, because these are your elected officials, and they work best when informed by their own constituents. So I would just say, I think this is a really important conversation to have, especially now. And I thank Maura and the team for having me.
Thank you so much for being here, Megan, representing the policy voice. Now we can take some time to reflect on each point. At the very top of the hour, I mentioned the issues that I have with healthcare, or the unmet needs, namely equity, access, and experience, ultimately improving outcomes. I'd love for each panelist to take a moment to sort of share what are some of the unmet needs in healthcare from their point. We'll start with you, Lauren, and then we'll go around. You're on mute.
Sorry, I feel like you are on mute is going to be the mantra of post-COVID era. Yeah, good question. And just really want to concur that the purchasers that I work with are also thinking about equity and health in a really big way. So this is a very important conversation. And not unrelated, two of the primary areas that we are very focused on, in addition to waste, which is an important conversation, are primary care. We need to strengthen primary care in this country. We have a handful of initiatives going on to do just that at PBGH, working with employers who are looking at different strategies, whether it's on-site clinics with primary care, whether it's relationships in the community for primary care, looking at new ways to pay for it, looking at new ways to measure it. Very important to beef up our primary care infrastructure. And the other thing is the quality of healthcare. I mentioned in my introduction that measurement is so important. We still have in our country, in our very expensive healthcare system, very poor quality outcomes. When I have an employer who's looking at some of their cancer data, and they are noticing misdiagnosis, wrong diagnosis, people who are, going down the pike towards chemo and other cancer treatments without really having cancer. Radiology results that have to be overturned. I mean, just until we can really focus on and improve healthcare quality, we're going to really miss the boat. One of the things that we have going for us in the healthcare space is that better quality is actually more cost-effective healthcare, right? You're getting the right diagnosis faster, the right treatment faster, not as much duplication, not as much waste. High quality healthcare is cost-effective. So we are all aligned on that goal. So primary care, quality, and waste, those are the major pushes for purchasers' attention.
Mary, thank you so much, Lauren. Marion?
Maybe I could build on the incredibly important and valid points that Lauren made and acknowledge that the question is a great one, but it's so big. And, I'll start with a little bit of a negative comment, but I think it's important to state it. Fee-for-service is resulting in fragmented, low-quality care. It's burning out clinicians. It's not letting them practice the way they were trained and wish to contribute and practice. And the pandemic laid bare how this fragmented care did not serve the nation well. And it also didn't serve the providers well. So we're at a moment in time, and I keep coming back to that. I'm excited about that. So my negative comment, now my positive comment. How do you address all the things Lauren talked about? And for me, it's alignment of incentives. And therefore, when I think about how to address, unmet needs, of which there's a million of them in my mind, you've got to align payers and providers, and in a way that partners them. You know, I may have a unique perspective with all these different roles, but I don't know all the answers. None of us singularly on this call know all the answers, but starting to talk to each other to figure out how to build a system. And one of the solutions I have to your questions is when we think about value-based care, where we're paying for outcomes. And when we think about population health, where we're paying for people to manage the population, and then that lets them innovate around how I'm going to meet health equities, access, social determinants of health, how I'm going to allow providers to have the infrastructure, to have care navigators, how I can think about partnering with the community health workers to make sure we're reaching into the community. So my answer to you is I really feel that we're at a moment in time. Let's keep on going forward. Let's not think we're going to go back to the old way of doing things. It didn't work. This pandemic just showed all the fault lines in it. So let's think about value-based care, population health approaches for paying for healthcare going forward, because we do have to pay for quality care. We do have to have metrics. We do have to have quality outcomes that we're going to pay for, and not pay for the types of instances of care that Lauren just alluded to.
Thank you, Marion. Juan, do you mind providing the provider insights on some unmet needs in the healthcare system?
Yeah, thank you. Both of the what Marion said and what Lauren said, very, very insightful. I couldn't agree more on the population health and the value-based component and how we align those incentives to make a lot of sense. I think we should invest in this country a lot more in everything that has to do with primary care and preventive care. We've seen the value or the lack of value that existed in our public health infrastructure over the past 7 months as we have to deal with the pandemic. And we've only paid attention to that because it's become a worldwide problem that has impacted our economy significantly. But the same problem exists when you talked about diabetes, hypertension, and other chronic illnesses that impact our population. As a physician or as a group of physicians, when we see something that needs addressed that requires behavioral change, we don't have the tools to address it unless we move to a model such as the one Marion was describing. And there's some really innovative models that groups and hospitals have taken when they've moved into that model in which they're able to provide patients what they need and have shown outcomes that things are changing from the positive at a lower cost and with longer and better outcomes. Behavioral health is also a big need, sort of from our perspective. A vast majority of what we need is behavior change. And the pressures and the tensions and the incidence of substance abuse in this country is skyrocketing by the minute. And that impacts everything that we do in healthcare and how we access healthcare services and how people manage their care.
Thank you, Juan. Megan, do you mind providing the policy perspective on unmet needs in healthcare?
Problem with going after three brilliant people is they said all the things. But what I will say is that from a policy perspective in Washington, I think what makes it difficult is that this is one of 15 very pressing issues that need to be dealt with yesterday, and so it doesn't always get the attention that it needs. And to Lauren's point about aligning incentives, that's something that Congress does all the time, because you focus on one piece of things at a time and then don't recognize where it sort of pushes the balloon on the other side, and then have to come back and fix it and do whatever. I think that while the pandemic did highlight a lot of the faults in our healthcare system, it also allowed us to spotlight some solutions that I think have been taking us a long time to really engage in, like telehealth and some other things that are very patient focused. I worked for two members with very rural constituents. The notion that they can now see a doctor through a telehealth visit rather than drive 2.5 hours to the next big city and get the kind of care that they need, or sort of the coordinated care benefits. I think Marian is exactly right. Fee for service it's not doing what we need it to be doing. We need to be doing more coordinated care, not less coordinated care. And to Juan and Lauren's point, the quality care is out there. It's there. We just have to figure out how we access it and how we drive patients there. And I think to your question, Christine, one of the unmet needs is, how do we help patients figure out what they're doing? I do this for a living. And when my mom asks me about some questions with her Medicare plan, I'm like, oh my God, okay, let me try to read it, right? If this isn't your full-time job and you're trying to help your parents or yourself, trying to navigate the system, we have done a terrible job in helping patients figure out how to get what they need. And we waste millions of dollars in services that people don't need because we don't know how to tell them how to get the best quality care. And I think that's the biggest issue we face.
Thank you, Megan. So my next question is directed to Juan. You heard at the very top of the hour, I mentioned my own patient story and not being treated equally. So my question to you is, what kinds of administrative systems are in place from a checks and balance standpoint for patients to report that they're not being treated equally, whether that mean from a racism standpoint, genderism, classism, et cetera? And how do you, as a system or provider system, help to ensure that the voices of patients are being heard as they interact with provider systems?
Yeah, thank you both for the question, and say for your courage to speak up. It's really important that we continue to listen to the voices of people who have unfortunately felt the negative impact of not being treated with equity and equality. Here at Evergreen Health, we looked at it, I would say, in 3 broad points. One is we want to avoid that to happen, and we do that by hiring and training our staff on a value and or a principle base sort of approach. Obviously, compassion, it's important. Obviously, respect is important. But to an earlier point, the MAR was making one of our leadership principles that we echo consistently is seek to understand before being understood. And that is one of the things that we encourage in our staff, because it turns your perspective around the person who's receiving care or your partner who you're trying to work with is the most important part of the element. We have also developed systems and structures to help us proactively listen to the voice of our community. Equity and equality, all the characteristics and all the different things is represented in communities differently. So we created a board of advisors from our community that represents the diversity of our community in terms of gender, ethnicity, sexual preference, as well as socioeconomical status, to make sure that we get good representation of how they're seeing our healthcare system. At the end, we're a community healthcare system, and they own, our institution. We've also made an effort to push diversity to be included in our board committees. We believe strongly that leadership changes the way we do and the way we act. So we've reached out to members in our community to participate to our different hospitals or different skill sets and be involved in influence where the hospital, where the organization is going. Finally, when proactively we don't do a good job, and that happens, unfortunately, we have mechanisms by which patients can reach their voice, whether it is at a local level in each of our clinics or care sites, as well as directly through our executives or directly through our board. We provide access where people can reach out directly to our board, and is mandated that we investigate each and every one of those instances. Through that process, our leadership has complete visibility of all those reports, whether there's quality of care or whether it's patient engagement or patient satisfaction, to make sure that nobody forgets that we're in all this together and we're able to learn from the lessons of other departments.
Thank you, Juan. My next question is to Lauren, as a purchaser in the room. As a patient, I'm unaware of the role that the purchaser play, and I've interviewed many patients, hundreds in fact, and I've never heard a patient point the finger at the purchaser. Rather, the finger is pointed at the payer. Can you please explain why is it that folks or consumers are unaware of the presence of the purchaser in the decision-making process?
So I think that it's such an interesting and telling question. First of all, for the audience, I often correct folks about this use of the word payer because the entity paying for healthcare is actually the purchaser. It is actually the employers for over half of our Americans. Over half of the people in our country get their health insurance through their employer-sponsored health plan. And those employees themselves, through their total rewards package and compensation program, and their employers are actually paying for that health care. So it's interesting, your question that patients don't think about purchasers, even though probably of the hundreds that you interviewed, many of them get their health care through their employer-sponsored insurance. And so they're actually the benefactors of those purchasers, but they don't really recognize that their employer is actually jumping through many, many, many hoops to try to buy them the best, highest quality, highest value health care. And frankly, I think this is one of our challenges. Employers have a really, really big job, right? Because they pay for more than half of the healthcare in this country. And frankly, the profitability of the healthcare system comes out of the pockets of employers. So they have a lot of power. They are the ones with the check and the pen. They are challenged because they are very fragmented. There are thousands of self-insured employers in this country, and there are hundreds and thousands of both of these groups of fully insured employers. They are the ones paying the premiums and paying the bills for the healthcare access by, like I said, over half of the Americans. But there are basically, if you think about it, 5 major health plans that have the big bulk of the business. So all of that market share of all of those employers is very consolidated down to a handful of health plans. There's basically 3 pharmacy benefit managers, PBMs, who manage the pharmacy benefits of all of those employers. Three pharmacy benefit managers in this country actually manage about 80% of our drug spend. That's not just amongst employers, it's the same 3 managing Medicare drug spend as well. The consolidation of the healthcare system makes it very difficult for those employers to have the kind of power that they should, given how much they spend and that they are actually the purchaser or the payer. The other challenge is that Americans, the very patients that you spoke with, Christine, they want lots of choice. They don't understand that all that choice, access to everything, access to everything that the doctor might say that they want, access to everything that they see on TV during advertising of, pharmaceutical manufacturers. They don't understand that all that access is not in their best interest. It is increasing the cost of care in this country. It is causing, it is the reason that we have a lot of wasteful services being delivered. And it is actually, giving them access to providers and systems and services that actually employers recognize are not always the highest quality, highest value, But for fear of having those patients have a bad experience, employers need to be very careful. Remember, what a benefit program is to an employer is a way to attract and retain very good employees, the most valuable asset they have in their companies. They really do not want those employees to be dissatisfied with their healthcare benefits. And as a result, wide choice, which, like I said, is not always in the best interest of Americans. So I really value your question. It's so interesting to hear that patients don't understand who the purchaser is, even though they are actually often the benefactor of those healthcare dollars spent by their employer.
Thank you for your insights. So my next question is, why is it that patients are not having a good healthcare experience if we're looking at healthcare as a business and patients are the consumers? We'll go with Marion, and then we'll go around the room.
Oh, another easy question. It often is easy way to approach it. What are we paying for? And being humans, sometimes that drives a lot of decisions that are made. And in the current system, we have a lot of volume. We just have a lot of volume. And if I could tell a story, I was recently at a health system, and I'm a chairman of the medical group board. I'm a chairman of a department, and I asked for a patient navigator. And I was very appropriately asked, well, who's going to pay for that? And I said, well, then let's work on that. And what I was asking for is a person in our department that would help navigate patients who have complex cancer problems through the system to get some all the different specialists to make sure they're okay and be accessible when I'm not. And, I get it. There was no way to pay for that. And so you end up with a system that doesn't reward people for the behavior that would meet the needs of patients. And it's not fair on providers. It's not fair for members. If you look back over the history of how we got here, I get it. I get why fee-for-service happened. But for me, a lot of the reason we're not meeting the needs of patients is because we're not paying for the right things. And we're not allowing people to build the infrastructure to have quality outcomes, to think more holistically about the patient. And I fundamentally believe it's inappropriate to expect physicians to deliver on that and health systems to deliver on that when that's not what we're rewarding them for. So, I think we've got a moment where we can help fix that, and we can help make sure we're paying for outcomes. And one of the most remarkable, wonderful things about my recent time in Washington was I started hearing about social determinants of health and how plans such as Medicare Advantage plans, which are Medicare plans that are administered by insurers, commercial insurers, how they're understanding that if we think about meeting the needs of the patient more holistically, if we do provide a care manager to help them manage their long list of medicines and make sure we help them get their medicines and adhere to them, what if we help them get to the doctor and to the grocery store? What if we help maybe pay for pest control if that data shows that it's helpful? If we make sure that we're really supporting them so that their health is all right, we're going to save money. So, I think we're starting to tip towards understanding what it takes to keep people healthy, but it's a transition. And again, my answer to your question, which is all too simple of an answer, it's not satisfactory, but one aspect of it is we're not paying for the right things and the right outcomes.
Thank you, Marianne. Let's just skip to the provider perspective on improving population health. One, how can provider systems or any kind of healthcare system collaborate across the board to improve health outcomes?
I'm going to build in what Marianne was saying because it's very important, and bring another example that is fresh in our mind, which is the pandemic. All alignment, all incentives in the pandemic were aligned. We wanted to protect the population. We wanted to take care of patients. We wanted to protect the providers that were taking care of those patients. We wanted to reopen our economy in a way that was safe. But in a matter of weeks, we advanced more in telehealth than in the past 10 years. All because somebody struck a pen and said, we're going to pay exactly the same amount that we pay for an in-person visit for a telehealth visit. And then we had the ability to go forth and care sort of for those patients in a very different way. That principle is exactly the same principle that we need to apply at a global level. And that's the same principle that I think innovators and creative innovators are helping disrupt in different sectors sort of over the market. There's a ton of them that if you go through different conferences, you'll see them trying to disrupt the payment model, align the incentives, and capitalize on the revenue that is available as they save that waste. We need to think about doing that at a global level through population health, joint risk-taking, understanding each other's perspective, understanding each other's alignment. Marian was saying something very, very valuable, that sometimes the reason why we don't necessarily impact health outcomes is because we don't address the right factor that is impacting their outcomes, that is, can get to the grocery store, or don't have somebody to help them at the home and they end up falling and breaking a hip. That hip is more expensive than being able to provide assistance through care. And I'll close this section and just as a very practical example of how we've tried to achieve this with the incentives that we have. About 5 years ago, CMS came up with a program called Chronic Care Management, in which it allowed us to provide ongoing care in an indirect way to patients with multiple chronic conditions. And we implemented this in our geriatric care program. And one of the things that we learned heavily from that in a geriatric care practice is how to shift from physician-driven outcomes to patient-driven outcomes. You know, the job or the outcome of the physician at the time was, let's control the hypertension, let's control the diabetes. The goal of an 85-year-old that we were treating at the time is, let's help me get to my granddaughter's wedding. I know I'm not going to be here for you, but let me get there in a way that I can enjoy that. We had a patient which we've been trying to control multiple chronic conditions for years, and we couldn't find out why. And through this program, we'll be able to bring a pharmacist to help her sort through their medications. She had a duffel bag of medications in which she threw all her medications and took things as she felt ill at home. That obviously wasn't yielding the right outcome. So in 1 month, that patient became sort of under control. So population health, alignment of incentives, and joint sort of risk-taking is the future. And we have to have the courage to move there and the ability to collaborate and give resources with people with different ideas to help us disrupt and make us uncomfortable.
Thank you, Juan. Megan, this next question is to you. When we think of our most vulnerable, people that are chronically ill, people that are on the lower socioeconomic spectrum, when we think of aligning incentives from a policy framework, what can you provide some insights as to what that looks like?
Sure. Yeah, I think you know, the theme of this conference should be align the incentives, right? Because that's really the answer to a lot of what we need to do. And on the population health side, on issues of socioeconomic status, I think Congress and the administration, not just the Trump administration, but the Obama administration as well, have struggled with this idea of how do you address that without creating some kind of two-tiered system. That if you know, providers, because they need this kind of assistance, have asked for reprieve from some of the ways that they are judged if their patients, if they have these patients who have a difficult time because of their other circumstances, because of food insecurity, because of housing insecurity. But then you get into a situation is, are we saying this is okay for a low income population, but it's not okay for a higher income population? And that's where Congress has really struggled with, how do you address these things while keeping the integrity of a healthcare system that we want to have? And I think that they are they and the administration have been working towards some good answers on this. And to Juan's point about sort of holistically caring for the patient, one thing that the administration has done is worked with the end-stage renal disease community, the folks who are on dialysis, because prior to this, you can't, if a dialysis patient can't get a ride to dialysis, they're going to go into renal failure and end up in the hospital. So a $25 medical transport to get you to dialysis, we can't do, but we can pay $250,000 for you to be checked into the hospital and get your dialysis there. And I think that the community has come together and they have been a really good example, Christine, of patients driving an outcome with providers and with payers. And so it has been the provider community, the payer community, and very outspoken patients. And we've worked with a lot of these patients, and they come to DC every year. And they talk about the experiences they've had, so that people understand that you think about these things when you're writing a bill or when you're drafting a regulation, but we are real people. And so what you're saying, your policy is, this is what it's doing to me. And I think, so that has been a really good outcome and kind of an example for how potentially other disease groups could look at this. I mean, from an ESRD perspective, a patient's on dialysis for 3 hours, 2 or 3 times a week, and that's a captive audience. Now you can bring in a podiatrist and have everybody's feet checked while they're just sitting there, rather than saying to a patient, hey, after this is over and while you're trying to live the rest of your life, you should also go find a podiatrist, get an appointment, get transportation there, and get these things checked out. And so when we make it easier on people to get the kind of care that they need, that's how the policy should be working. And so I think that that's a really important kind of discussion that Congress is having, not just in the ESRD space, but in other chronic diseases where they are trying to figure out how to put the patient at the center of the discussion.
Thank you, Megan. So I've met so many patients that have had trouble paying their medical bills and have had trouble accessing healthcare because of a cost barrier. Marian, can you please get into how does cost impact access, and what can be done on the payers end to make it easier? Or why is it not easier for patients to access healthcare because of cost barriers?
So, sometimes I think you start up here and then you kind of go down to the specific answer. So I'll address that. We as a nation have to make some decisions. And we have to decide how we're going to pay for people who don't have the ability to pay for healthcare. And we need to think about those that are self-employed. And we need to then address, I think, the biggest problem, which is when you think about how much it costs a family of 4 to be insured every year, you could buy a new car, kind of a nice new car every year. Is it $28,000 a year? It's in that range, but it is a huge amount of money to insure somebody and a family. And we, I think, have to understand that it's unsustainable. And so thinking about innovative ways to overcome that will require policymakers. It will require people thinking about how we're going to value healthcare. So we, as a payer, because that's what you asked me, we have sort of specific things we think about. We have purchasers come to us, and they have employers that can pay so much, and they're asking for certain benefits, and we negotiate with that. We have individuals, and we have exchange products with the Affordable Care Act. We have exchange products, and we work on making those affordable. And then we have fully insured products, and some of the answers lie in how much it costs a patient in out of pocket. And I think that that's a huge driver. That was sort of an aha moment for me. Sometimes people really on fixed incomes really, okay, they budgeted for certain things, but what is the out of cost part of that going to be for me? So we have to keep an eye on that as well. And so thinking about health savings accounts are an important way to do that. Thinking about new ways to overcome that are important. But part of the answer also for me is getting outside our box, thinking a little bit even more broadly. What if we did a couple of things? At Cambia, for instance, we have a foundation, and we're very proud of our foundation. We're a mission, we're a non-for-profit. We have a cause, which is our mission. And so we very much value working with a partnership to lever things. So with these, thinking about public-private partnerships, for instance, what if you had a public-private partnership where you're helping to think about how to leverage community resources and help with foundation work, support that. When you think about community health workers, the impact they can have for certain populations, it's really helpful. So, you have to leverage a whole bunch of different things, but it's not just the payers that bear this burden of figuring this out. It's all of us. And I really want to end with that. That's one thing my journey through all the different sectors has taught me. It's not just one group that's going to figure this out. It's going to be all of us working together. And at the end of the day, it's what we value. Do we value widespread access? And I think that's an important conversation we probably need to have.
Thank you, Marion. Lauren, from the purchaser perspective, how can we make healthcare more affordable for Americans?
So the reason that cost share is so high for Americans is because healthcare costs too much. And specifically, employers have adopted a cost share strategy really for two reasons. One, there was some thinking that, wow, if individuals understood how much care cost, maybe they would engage more directly in looking for higher value solutions or staying healthier. So there was this notion of consumer-driven healthcare, which is really the early days of the HDHP, HSA. So that is a strategy that has been undertaken not only by employers, but by CMS with the whole donut hole concept. There was this thinking that, wow, there are variations in cost and value of all of the services and healthcare products being made available to patients. And if we can engage the patients in caring about that, then they will buy and move the market towards a more cost-effective, value-based system. And so, that's really great thinking, but unfortunately it didn't work for two reasons. One, it's really too complicated for patients to figure this out. I mean, the data is not good, the quality data is not there, the cost data is not there. It's very complicated, near impossible for patients to figure it out. And what studies have shown us is that they cannot differentiate between high value care and low value care. So if we make care too expensive for them, they actually just, avoid a lot of care, and with no distinction between what's high value and low value. And that's not good, and ends up sometimes costing more in the long run. Healthcare costs too much, which is why cost sharing for patients is too high. And putting the impetus on the patient to figure that out and impact it has not worked. I often say the worst thing that ever happened to healthcare and the best thing that ever happened to healthcare is consumer-driven healthcare. Why? Because it's the worst thing because patients cannot access care because care costs too much because there's too much cost share being put on their shoulders. But why is it the best thing? Because it did wake Americans up to the high cost of healthcare. And in our country, the impetus for change is the voice of American citizens. And so having Americans say enough is enough, we cannot afford this, has really empowered our policymakers to get involved. They will get involved when their constituents tell them we can't afford our drugs. So it is really the pain point that we hit because of the very access and cost issues that you referenced that is making it mandatory for us to change. Now we want to change in the right way. right? Let's hope that our change is productive and successful, but there will be change in our healthcare system because this is now unsustainable. Americans are feeling it in their pocketbook and using their voices to say, enough is enough, please fix this.
Thank you, Lauren. Americans are not able to afford healthcare. They're not being treated fairly. What is the provider's take on that?
I want to highlight, I think what's been described before is really the key. Just an example of where it's worked well, because there's pockets of the country where we're addressing this in very small. One of locally here in Washington, the Healthcare Authority a couple of years back convened policymakers, payers, and providers to set up something called a Public Employees Benefit Plan, which is standardized the benefits across all public employees, and then extended that also to the school employees of the public school districts. So now it's an all-encompassing plan that provides uniform benefits, and different companies compete in different regions for those populations in their plan. The beauty of that plan is not only the standardization and the collaboration and what should go into that plan and how it's regulated, but also that it generated a significant amount of savings for the state itself and for the patients, to the tune that after a couple of years of running the program, because of a statutory design of our benefits, the state had to return money to the consumers who had overpaid their premiums. And in an effort to continue this problem, instead of giving them a check that we could spend anywhere else, buying a new TV or a new car, or, spending it on Amazon Prime, they put that into a health savings account for people to continue to use in their healthcare needs. And they educated, the members of the plan on why a health savings account was important. My wife's a teacher, and when that information came through, she says, oh, this is money that we need to put away from we're old and have really expensive medical bills. So that's a good example of how when policymakers, consumers represented by either unions or individuals, the purchases of healthcare that are the employers or big state entities, and providers work together, and yield a fantastic result. Now, reproducing that system at a broader scale, it's incredibly hard because at the same tune, we're competing with each other and trying to align. So that's one of the bigger challenges we still have.
Thank you, Juan. So this next question is directed to Megan. Megan, do you mind sharing your perspective on people's voices being valued? So I've traveled across the United States, 23 plus states, have met with folks in the streets. One of the biggest concerns that I've heard was that people's voices, that politicians, quite frankly, don't care about people, whether that means because of where they live or because they feel as though they have no say in that decision-making process. So how can we empower folks in the community, patients, if you want to call them consumers, to have a voice and to know that they play an important role in the decision-making process in our policymaking?
Yeah, first thing I'll say is I know it's a very popular position that members of Congress don't care. They just here to, I don't know, get sacks of money and do whatever it is that they're doing. But the truth is they're human beings, right? They're people. They're here because they think that they have a voice to represent their constituency. They have moms who have breast cancer. They have dads who have prostate cancer. They have kids who've had childhood diseases. There are people who experience all the things that we experience, and they respond in that way. So I think that we tend to lump them into this big. There was always, for a long time, there was this kind of trope in DC that like people hate Congress, but they like their congressman. It's easy to like vilify Congress, like, I think that's a place that people go. But the truth is a lot of stuff happens here that people don't realize, because it's not some big showdown on the floor that is exciting. It's not clickbait or something that gets the headline. And that most of the time happens from groups like this, from people like those people attending this conference, from people like Maura, and working with the kind of folks in the community, with people like you who organize patient groups and bring something to Washington. The idea, and I'll give you an example of one thing, is there's a bill that was passed 2 years ago called ACE Kids. And it is a bill to address the needs of kids with multiple complex medical conditions. These are not kids who are ever moving out. These are kids who were born with their organs outside their body. Their parents have a full-time job of their healthcare. And Medicaid is not easy. And the vast majority of them are on Medicaid because of just the sheer cost of their care. But they, as a community, parents and patients, came together with the children's hospitals, because, as going back to our theme of aligning incentives, the incentive for a children's hospital is to have a patient in the bed. That's how they get paid, and that's how they keep the doors open. The incentive for these families is to keep their kids out of the hospital. So they came together and really worked together as a community of patients, providers, and payers, and Congress and policymakers, to say, what do we do here? And it took a while, as these things do, but they were able to pass a law that says that these hospitals can be hubs, they can be medical homes, and they can help coordinate the care. It helps them keep the patient at the forefront. It helps them help the parents who are overwhelmed with a system that is impossible to understand, and it aligns everyone's incentive to putting these kids first. So I'm probably a little Pollyanna about Congress, because I still love it, even though most people don't. But I really think it works when people bring their voices to Washington with their ideas, with examples of, look, this is what we did and it worked, and it can work for you. And I think that means something. I would also say, I mean, obviously with COVID, please don't come here. But when we get back to a time that we're in a more normal setting, talking to your senators and congressmen at home is really very impactful. Here, they're running from a committee meeting to a vote, to a this and a that, and inviting them to your organization, showing them what you do, having them be in your facility or with your patients or at your round table to talk about the issues that are important to you, that sticks with them.
Thank you, Megan. And Juan, what can patients do to be heard when they're encountering the healthcare system?
I think patients need to continue to speak up. It's very important. As providers, as administrators, as part of a healthcare system, we understand that we're here to serve the patients. Sometimes doesn't go well, but I would encourage patients to continue to speak up. And if they are not listened, to speak out louder. You will find a voice in the providers, in the health system to listen to you. We need to continue to change and evolve and work together to keep the patient at the center.
So as a patient, I want to receive health equitably. I want to receive health efficiently and in the most cost-efficient way possible. I mentioned that at the very top of the hour. If we could fix healthcare with each and every stakeholder on this line right now, what would you do? I say, if it's the magic wand, so to speak, what can you do to improve healthcare access and patient experience? We'll start with Lauren, the purchaser in the room.
So that's a really big question. And I would go back to a conversation we had earlier, which is to say, if there is a magic wand, it's called payment reform. We must pay differently for healthcare. Nothing will change until we do. The challenge is that all of the misaligned incentives and overpayments and over-medicalization and wasteful procedures that are being wrought on patients because of these misaligned incentives, those dollars are salary to somebody. Those dollars are profit to somebody. So the only way to take money out of the system is to, at the end of the day, impact somewhere, somehow, money that someone is bringing home and enjoying. So we need to figure that out, but it needs to happen because nothing will change if we don't change the way we pay for healthcare. And that would be the magic wand, which is not, and I would say that's not one fell swoop. I mean, there are all the challenges that I discussed earlier with the consolidation of the healthcare system, which makes it very, very difficult to do that. But in addition to that, there is no magic pill. There is no one way that's going, saying payment reform is great. Now let's break that down into 18,000 different opportunities. And whether it's the way we pay for our specialty drugs in this country on buy and bill, or whether it's the fee for service system, or whether it's the fact that primary care is paid at 1/8 of the value of what they're providing based on the volume that they're addressing. I mean, those are all individual challenges that need to be addressed one at a time. And unfortunately, the infrastructure that we have to address that, our infrastructure of health plans and big health systems, big hospital systems, the American Hospital Association, my list can go on and on and on. They're doing very well right now. Thank you very much. And it's not easy stuff. And they're working against the personal interest of all the individuals that they count on to have their product work. So this is not easy stuff. But if we're going to talk magic, I'd start with payment reform.
Thank you, Lauren. Marianne, from the payers' perspective, how can folks work together, or how can the payers work together with the other stakeholders to improve healthcare access and much more?
One thing I thought I might add is thinking about earlier questions in this one, which talks about equity and feeling disrespected and treated differently. And I want to make an important point, and I think this is where payers can help. It occurs to me that if I felt as a consumer of healthcare disrespected, and it probably wasn't because of my ethnicity or anything, it was just because of a fragmented health system. And so one of the things that aha moment for me was in my prior career at CMS, we were trying to tackle a huge issue of healthcare systems and maternal mortality, morbidity. And, I hope that some of that work rolls out. But if we can make all health systems a little bit safer, and what I mean by that, and safety and education bundles, so that health systems, if you're a birthing facility, you know how to respond to an emergency from maternal care, and you know how to respond to hemorrhaging, and you know how to respond to possible stroke with the hypertension. And so there are systems out there, and a lot of them are joint projects with professional medical societies, incredible expertise, but we don't have widespread adoption of safety programs in our facilities, as an example. So as payers, I think it's important that we encourage health systems and pay for it, have quality programs where we're paying for these systems of care, so that when you go into any hospital, I'm using birthing for one, if you go to any hospital as a woman and you are that facility is licensed and you're as a payer, you're going to pay for it. You know that you're raising the bar, because all these facilities now have to meet this system of education and safety that's credentialed. And so for me, that's one example of how a payer can help, because I worry that sometimes if you're in a community, you might feel more welcome and comfortable at one hospital over another one. Like the big health system might not be as welcoming to you, so you go to the one you're more comfortable at. And there might be differences in how they are prepared for emergencies, how their safety systems are. So one of the things I want to point out is, as we tackle diversity, making sure we're, as payers, raising the bar for all health systems and being clear. We can harmonize these safety programs across multiple payers, the federal government, and then other commercial payers. But that's one way we can help with people not feeling disrespected. That's the way we can help all populations, underserved, rural, come up to speed. But it will require that we help support those types of programs as well. In terms of access, I am excited about the opportunities for telehealth to help us with that, but it'll be much more than that. But this is the moment of innovation where we can think about how we're going to encourage what we're going to pay for, what is good use of telehealth for increasing access. It strikes me, Juan pointed out earlier, behavioral health is ideal for that. We'll never go back, and nor should we. It's going to help us hugely in that field. But let's keep on going. Let's keep on going to think about how we're going to do that. But making sure we link those visits back to the primary care physician, so we're not fracturing care going forward by having people seek care all over the country with these vendors and telehealth. So think a little bit right now at this moment about how we're going to innovate around access to really amplify and help the primary care physician in that health system, in that health system not be involved in population health. So those are some of the vehicles I think that payers can use to help take concrete steps towards helping people not feel disrespected and not be disrespected and treated differently, and then also help with access, which are two huge issues going forward.
Thank you, Marianne. One, how does the provider work together with the other stakeholders, the policy, the purchaser, payer, and the patient to improve healthcare?
Yeah, and I'm gonna also take the magic wand that you gave to Lauren and try to see if I can build my my fix over the healthcare system. But I think over the past few years in our market, we've worked collaboratively with our payers and the employers and policymakers. Certainly pushed by what's happened around us. The competition from Optum and Kaiser coming into our market has changed the way we've looked at the world. So we have some really innovative programs with Microsoft. We have a product called Connect, in which we offer a differentiated care at a lower price with better access, in which Microsoft and our clinical integrated network, as well as Primera, sort of participate in this program. In other instances, we've aligned on shared objectives with other payers towards goals that were mutually beneficial for us, whether it's access to preventive care or improving new programs or reporting of quality metrics, and so on. And I think one of the things that gets underscored in this whole payment reform debate is how hospitals and providers get paid. It's really complex, but one of the things that we don't pay close attention to is that the biggest system in the room ends up being the system that gets the more money for the same services, versus the smallest system, because they don't have as much leverage in any particular market, gets less money. But the needs of that smaller system, say in a rural area, are much higher because they have less access, they have harder time recruiting providers of quality care, nurses, and so on. To move there. So if there was a way that we could reward, smaller systems in rural areas financially versus the bigger system in larger metropolitan areas, I would weigh that one, because that would help provide better quality outcomes. They'll have the resources that Marian was mentioning and elevate the quality of care for people who have the harder time accessing.
Thank you, Juan. Megan, from the policy perspective, how do we all work together from both the patients, purchasers, payers, everyone else?
Yeah, I mean, I think that I agree with Marian. We're at a critical moment right now. I mean, this is an opportunity, and I think that one of the things, and especially, I know I'm the one on the East Coast over here, but for those of you on the West Coast, there's a lot of technology companies. Although, if you believe the news, they all live in Houston now. So I don't know where the technology companies are, but empowering the consumer is the answer. And I sort of flippantly say this, but it isn't that flip. The healthcare system is like we bought a one-story Rambler in 1965, and every time we needed something, we just added a new room to it. And now it is the $2 trillion least functioning house in the history of the world, with 7 kitchens in the attic and no bathrooms. And then we don't understand why it doesn't work. we're not going to scrap that system. To Lauren's point, the equities are too high for everybody involved in it, that we're just not going to scrap it and start from zero. So how do you empower a patient in the middle of that to get the care that they need and make the system change to them? Part of that is that direct information that a consumer has. You know, the consumer, the notion, Congress does this all the time, where they say, hey, hospitals, you need to post your prices. And then they post a spreadsheet in 9-point font with HCPCS codes on it. And only the four of us are laughing about that, because nobody even knows what HCPCS codes are, right? So what does that do for a consumer? How is that helpful? Or even, to be honest, when I understand the point that the Trump administration was trying to make, but having drug companies tell you on their commercial how much their drug costs, who does that cost? Does it cost me that money? Does it cost my employer, my insurer? Does it cost the doctor that? I don't understand. We're not giving people the actual information they need. We're just throwing information at them and expecting them to get a PhD in health reimbursements and figure out this themselves. Where technology comes in is, I can find anything I want on my iPhone. So what we're looking at now, and some of the cool things that are happening, I know at Cambia and other places, are have it on your phone, have an app on your phone that is integrated into your plan that says, hey, Megan, you're in the doctor's office right now, and I entered a drug that my doctor prescribed to me. And just so you know, that drug in your plan costs $2,000. But these are two other equivalent drugs that you should talk to your doctor about, because they cost $7. Right? Like, why isn't that happening more? Because what happens right now is, I go to the doctor, I get a prescription, I go to the pharmacy, they tell me it's $2,000. I say I cannot possibly pay that. So then I make another appointment with my doctor to go back and take a day off work to discuss the fact that I can't get this prescription. And now we're 6 months down whatever path I needed for treatment that should have taken 5 minutes. And so, to me, empowering the consumer in a way that they are empowered in almost every other sector of our economy is the only thing that's going to change it. That to know, for you to know, and not just aggregate costs, but for you to know what this means to you personally. And I think that's really that's my magic wand.
Thank you all for sharing. One of the questions that came through the Eventbrite registration was, how can I engage with patients from a government purchaser perspective? So we'll start with Lauren on this. The question is, how can I engage with patients from a government purchaser perspective?
I got to talk about what Megan said before we go there. So, so just so that folks in the audience know, Megan was not exaggerating when she said the doctor prescribed something that cost $2,000, but a therapeutic alternative is available for $7. That is not an exaggeration to make a point. Okay, Megan is not making that up. That's real. And there are examples that we can cite again and again and again that are even bigger than that. Thousands of dollars for a drug prescription that is unnecessary because it is profitable for the intermediary to include it on the formulary, and the doctor does not know what the drug costs. Very important point. But I would also say, Megan, I appreciate what you're saying. We really need to think about what the cost to the patient is, but we also need to think about the cost to the plan, because what happens with that $2,000 drug, and I know you know this, the pharmaceutical manufacturer puts a coupon in the market so that the patient does not incur a cost. And then the doctor might actually have a bunch of these coupons in their drawer, and they're like, oh, this will cost you nothing, which the doctor cares very much about what the cost is to the patient. So we have a situation where we got to step back, not only look at what the cost to the patient is, we must look at what the cost to the plan is. Because the more the drug, service, device, whatever, cost the patient, the more likely you will find the benefactor of those profits subsidizing the patient cost share so that they don't actually have to pay. And who is paying? The employer, society, the taxpayer, etc. We need to be very mindful of the total cost. Okay, I am so sorry, Christine. I just had to say that because I was laughing about the $2,000, $7 differentiation. I don't fully understand your question. I'm so sorry. Can you repeat it?
So the question is, how can I better engage with patients from a government purchaser perspective? This was one of the questions that came through Eventbrite.
From a government purchaser perspective?
That's correct, yes.
You know, I'm going to say to my other panelists, please kick in here. I'm not 100% sure I understand the question, and maybe, yes, Marianne, thank you.
Are they talking about Medicare, Medicaid, and CHIPS?
Oh, I'm not quite sure. That's exactly how the question was framed and how I'm reading it.
In case it's helpful, in case they're talking about Medicare and Medicaid and the Children's and Health Insurance Program, CHIP, one thing that's important to know is this government agency that is housed in the Health and Human Services Department and has a $1.3 trillion annual budget. They have only certain vehicles by which they can do things. And one of the important ways that they set prices and create new policies, and I wonder if this is what they're asking for, is by rulemaking, and they have to do it. And the great news is that there is comment period. They have to have, usually it's a 90-day comment period. And those comments are incorporated, and I can tell you they are read and they are heard. So I hope one of the answers to this question is that for your federal government, and Medicaid is often run by the states. That's an important point, but there are some policies that are created at the national level. There's a comment period, and you often it's groups. It's not an individual. It's a group that will band together and submit a comment, but they're read. And if the administrator or one of us met with a group, we incorporate that so the voices are heard. Now you can imagine across the nation, there's a lot of diverse voices out there. But if there's a majority opinion that comes out of that comment period or via meetings that we have with diverse groups, that is absolutely taken into account. I hope that's getting at what the question was asking.
Thank you for answering that. One, there's a question here for you, and that is, what gaps needs to be addressed on the front lines? So can you provide some provider perspective on that?
Oh, I mean, there's a ton. It just depends on how you want to frame it and how specific you want to be. But let me go back to we've been talking about primary care and population health and coordination of care and communication. I think in this moment of change, like we've been mentioned, that's one of the key areas that we should focus on is how do we get to coordinate between all the different stakeholders that can help prevent disease from growing in a person or spreading or addressing early on. Investing heavily, for example, on care navigators or health advocates or health educators in a way that helps people understand their health and why they do it, and do it that in creative ways. It doesn't have to be your traditional, hey, come to my office appointment or even a telehealth. We all learn in very different ways, and just let's customize that for the specific person. Let's give people priorities. Let's create incentives for people to change behaviors in a way that works for me. Can we address some of those behaviors even before we become adults through our school system and through our public health sort of mechanisms? How do we get systems in place so a primary care provider has the time and the dedication that they need to see that patient in the eyes, to fully care for that patient and not have to worry about the ton of documentation that needs to take place to get paid $85 or $90 for that 15 minutes or half an hour of work. There's a huge burden of innovation. So we can talk all day and every single different specialty through the healthcare system. There's tons of those. So what I would say is I would encourage, the people in the audience and the people who are innovators and want to disrupt to reach out to the different healthcare systems in their community and spend a day in the hospital and see what you find and see how you can improve it.
Thank you, Juan. Another question that came in was, how is the pandemic causing disruption to healthcare reform and ways that it can tackle systemic racism to improve, with the aim to improve innovation? So I'll read that again. How is the pandemic causing disruption to healthcare reform and ways it can tackle systemic racism with the aim to innovate?
Well, I'm happy to just say from my perspective, I think one of the things that the pandemic has done, and I think everyone, Lauren and Marion have all highlighted this at different points, is we have really been shined a spotlight on where the cracks are, what the problems are. And I think that certainly what the pandemic has done is to in a very real way and a real time way show the kind of racial and socioeconomic disparities, even in the vaccine distribution or in infection or in access to testing or in all of the different issues or in the last 8 months that we have faced around the pandemic. So I think we've all talked a little bit about telehealth, and I don't by any means think that that is not a magic wand. That's just a good thing and a good policy, but it's also a good thing and a good policy that we in Washington have been talking about for a dog's age, and that it turned out that when it really needed to happen and when we had to do it because there was no other choice, well, looky there, we figured out how to do it in a matter of a month. And so I think that's one of the things that is the disruption has been that these things are possible. They're possible quickly, and they're possible without stopping the world from spinning on its axis. And I think that we need to take that and try new things in a more fluid way. And the federal government is not exactly designed as a nimble operation, so we don't do a great job in kind of adjusting to things on the fly. But I think the pandemic has really been a microcosm of the issues that we face and the things that we could do to fix it.
Thank you, Megan. On that note, I'll pass it back to Maura for audience Q&A.
All right, thank you, Christine. Before we get to audience Q&A, I'm going to turn the question back to you, Christine. You wave your magic wand. What would you do?
For me, it's really simple: improving access for our most vulnerable population, improving patient experience in the way in which people are treated from an equitable standpoint, but also in making the experience easier. So having technology bridge some of the existing gaps that exist in healthcare. And also having those checks and balances in place where if a person does not feel as though they're being respected or receiving health equitably, that their voice can be heard in those systems. Because as a patient, I've felt the frustration of not being heard, and I want to make sure that every patient can be heard. So it would be great from a systemic standpoint, from either an institutional standpoint, to have policies in place to protect patients, to help empower their voices as they're interacting with with these systems. And last but not least, that our broader society itself, that there is policy in place to make sure that everyone is accessing health equitably.
So one of the things that we do at Cambia Grove is we look at the 5 points, we look at aligned stakeholders, and we think about who has the levers to pull. When we think about the full journey of someone's life, right? Keeping a healthy life, not many of the points have incentives other than patients, consumers, individuals themselves to keep that one individual healthy. So my question to the panelists is around who goes first. A lot of people have talked about the patient voice, but as we all know, the patient's voice can sometimes not be as visibly heard. So Megan, I want to ask you first, because it's bird's eye view on government. Who do you think needs to go first in terms of incentivizing health for the long term?
I think it's a great question, Laura, but I think the answer is no one can go first. It's not going to happen unless we go together, and that's the problem. And my old boss used to say, "Good things happen in divided government," because when you do have divided government, you're able to say, well, it wasn't my fault. So-and-so said, made me do this, but I got this done. So you get to take credit for the parts that you like, and you get to blame the other guy for the parts you don't. And that's politics, right? And so if you're looking to see how you address an issue that's this hard, you got to all go together, because when you're the first one to step out on that limb alone, it's a very scary place to be, hoping that the other folks aren't back there with a saw trying to make you the bad guy. And we are all the good guy, and we are all the bad guy. We all have a part of the blame for why this system isn't working, but we all have a lot of good that we're trying to do to make it work. And none of us have all the answers. And I think that's clear here. These are some of the smartest people that I've had the privilege of being on a panel on. We don't know. So I think if we don't do this together, we're not going to do it.
Mm-hmm. Other thoughts? Marion.
The CMS has a $1 billion a year agency called the Centers for Medicare Medicaid Service Innovation Center, and we call it Innovation Center. So $1 billion a year they spend on coming up with new payment models. And the neat thing is the payment model is on top of new healthcare delivery systems. They define what you're supposed to do to get paid. And they, when I left, they had 40 plus they were looking at, they're honing them down, they're trying to learn, and they're pumping out new ones. And I think my point is, I think that shortly some of those models, there's a good chance, and depending on the new administration, I'm going to bet you a nickel that some of those payment models will become mandatory. And so to the extent that we can become multi-payer, we can think about what we want to support. And a lot of that's around population health, direct contracting. Megan brought up earlier the end-stage renal disease models, which push patients towards home dialysis and transplantation. Brilliant. Quality of life's improved, health outcomes are improved, it costs less. To the extent that we can then, as payers, have a multi-payer approach to these things and support it, to the extent that we as payers can harmonize in partnership with providers and hospitals, figure out what's really going to move the needle on quality metrics. So there's not 65 quality metrics, but a number of a parsimonious number that are truly instrumental in moving forward. To the extent we can harmonize quality metrics and think about outcomes for the providers and systems, think about payment models that we're going to have multi-payer. I think that's a concrete step towards what Megan just described, where we are marching forward together. And I think that's doable. I think that's eminently doable.
Mm-hmm. Yeah. Okay. Any other thoughts on that one? Going together? Perfect. Question for Christine. This one just came in, and we've got some incredible questions in our Q&A chat box. I'm going to try and get to as many as possible. But Christine, what are the different ways in which you think technology can bridge the gap with improving experience for patients from different backgrounds? And one of the things as you think about that is we've got a lot of people on the line who are building businesses to potentially, hopefully, help patient experience, patient care. And a lot of times there isn't the hardest ear to bend is the patient, because it's hard to get in touch with individuals. The fact that I just said that and kind of cringed can probably be an indicator of probably shouldn't be. We're all individuals, but having that consumer feedback is extremely tough in healthcare innovation. Christine, different ways that you think in which you think technology can bridge the gap with improving experience for patients from different backgrounds.
Sure. I like to think of people that live in rural areas and their inaccessibility to healthcare in comparison to someone who may live in a metropolitan area. I think we can bridge gaps such as transportation, food, clothing, shelter, et cetera, using technology. And then that also applies to that equity lens when we're thinking about improving access for our lower income communities, regardless of location. And in addition to that, I think when we think about the experience piece from the patient perspective, at least from my patient perspective, that essentially involves data interoperability. I gave earlier on my example of being seen by 7 different doctors before actually being prescribed pain medication for my issue. I imagine that if these different systems were communicating with each other, that they would have seen that I'm not a drug-seeking adult, that I am someone who is in pain, and that all of these different systems are repeatedly ignoring my concerns, and that my healthcare needs are not being met. So from a technology standpoint and the data standpoint, I think if we can improve interoperability that way, that's great. And from the equity piece, I think connecting those services that folks so desperately need to improve their health outcomes would be great.
Mm-hmm. Oh, it's important. That infrastructural element of interoperability across systems it's incredibly important to deliver care. Juan, you just got off of mute. What do you think about the interoperability and where we're at as a country?
Well, I love the point. I was going to add that also the portability of the medical record is very important, and we haven't done any work on that. The reality is, in this world, we're very, very mobile. Today, I'm in Washington State. Tomorrow, I can be in the Middle East or in Asia, and my medical record hasn't changed. But I can't provide physicians who are going to treat me in an emergency, or if I need any refill or any care, the information that they need. So portability is key. It's my medical record. I should be able to have it and have access and put it wherever I want. And the interoperability is when somebody touches it, how do we make sure that it's updated in the right way? And we've made significant advances on it, but it's still very, very, very painful. Because we've put a lot of data, and not all that data is clean. So now we have to figure out, how do we go from this large amount of data and HIE and all the other exchanges that happen, and make it clean and narrow it down to the information that we need. I made a comment before about, getting providers the information that they need so they can focus on the patient. One of the big obstacles that we have to turning on this interoperability is that you turn it on and all of a sudden you get, gigabytes of information plowing down your screen, and a reasonable provider is not going to ignore that information. They're going to want to read it and process all that because they feel responsible now that is on the screen. So how can we synthesize that and clean that up in a way that is usable at the point of care for the provider and the benefit of the patient?
Mm-hmm. So a lot of talk around interoperability in DC. And Marion, I know you've spent some time on it too. Added thoughts?
Yeah, can I just spend a minute to make sure everyone's aware of the tremendous leap forward we just made. The 21st Century Cures Act mandated that there be increased operability by July of this now new year. And so they're looking at what we call APIs, application programming interfaces, so that that interface allows patient to have their data put in, especially from CMS. And so what CMS calls it is Blue Button 2.0, but the patient, the member, tells us, especially claims, enrollment, and healthcare data goes into that application programming interface. And then the patient has the ability to send it to a payer, and the payer can put in, if the patient wants, and send it to an application. But that API then, using standards, is a foundational piece that will allow this to happen. And the standards are FHIR, FHIR, Fast Healthcare Interoperability Resources. But through many administrations, this work has gone on, and it's exciting to see it come to fruition, because the importance of having standards when you're sharing data and having some guardrails around it, that this is an API. And so now that 60 million Americans, if they wish, in Medicare, can have their data put into this API, and innovators then work around that API and they innovate around how that data will be shared and for what use. But it's amazing, it's remarkable. And if I could tell one 10-second story, you know, this happened because the current administrator, Seema Verma, pushed it, and it's her story, and she's told it publicly, so I'll repeat it, but her husband had a major healthcare scare, and he's fine now, he's a lovely man, fine. But when she went to get his records, they handed her at this world-class academic medical center a CD-ROM. And she went, what? And so, you know, this new rulemaking and the demand to use standards and this API, it just pushes us light years ahead towards what Juan's describing. And I think that's really a moment to have great hope and marvel at how far we're coming and how far we have come.
And it goes back to Megan's point about empowering the consumers and being able to empower those consumers. One of the questions, because I know we only have about 11 minutes left, one of the questions came in early on, and it's going to you first, Lauren, but I know others will have thoughts about this, especially my team at Cambria Grove, as we were working with the AMA, AHIP, ACLC, and Christine with Patient Orator on a payments and incentive hackathon coming up in February, where a lot of the questions are on how do we incentivize, well, the truly is how do we incentivize health? This question is from Jennifer Keene, and it reads, how are purchasers thinking about value-based care balanced with metrics, balanced with metrics based on patients' point of view? She says, it's my experience as a provider that patients often request studies such as imaging studies that aren't indicated and don't feel heard even when time is taken to try and understand why they are interested in that testing and explaining why it isn't the right test right now. So the metrics, and how are purchasers thinking about that?
So this is a really great question, because it actually brings forth two kind of world truths that I suspect that we can all agree with. One is that what we, follow the dollar, what we pay for gets done. Okay, that's an issue. That's a world truth. Follow the money. And the other one is what we measure gets improved. We cannot really improve anything until we measure it. So if we combine those two sort of world truths, we have that question. How do we make sure that we're measuring the right thing, because that is what's going to improve? And then how do we pay so that it makes sense that that can improve? I think that's part of the Holy Grail. And I mentioned earlier in my introduction that one of the things that PBGH is blazing a trail towards with some partners across the country is patient-reported outcomes. So historically, what we really evolved to in our healthcare system, thanks to the very good intentions of many, is measuring what we can measure. Was a mammogram given? Was a PSA test? I mean, these are the things, these are the HEDIS measures, the early days of our measurement. We measured what we could measure. But is that really, those are very important things to measure. So don't want to be misunderstood. Those are important things to measure. But are we really measuring what we need to measure, what is meaningful? Is this treatment working? When did this person get back to work? When did they stop throwing up? When did their fatigue stop disabling them? These are the things that we really need to know from the patient's perspective, how effective our healthcare delivery is. And that is I think the roadmap for measurement is to move into patient-reported outcomes so that we can really understand what is working. So, and then pay for that, by the way. So first, measure it, measure what counts, and then pay for it. I will add one more note to that question. We have created a tremendous burden for our providers and our healthcare systems in general, but certainly for our providers with, and I think Marianne referenced this earlier, all of the different measures. I mean, there are hundreds and hundreds of standardized measures. And honestly, here's the irony of it. Even within those standardized measures, take anyone's standardized measure and talk to a doctor about it, and you will hear that they are being measured in different ways. So we really need to get serious about identifying what counts and cleaning up just this measurement mess that we have found ourselves in our effort to measure. So, you know, what gets measured gets improved. It will not get improved until it gets measured, and we will keep doing what we are paid to do. So I really appreciate that question.
Mm-hmm. Other thoughts on that question? We started with Lauren. Did anyone else on the panel have thoughts? Juan.
I think a good example of how the pandemic has helped us move in patient-reported outcomes, actually, many of us are going to get to see in the next few months as the vaccine gets rolled out. And it's what NIH put together with VCare, which is a patient-reported outcomes as people receive the vaccine. It's like a 30-second online thing that you do on your phone to report, is your arm swollen, itching, have you had any side effects, fatigue, to be able to collect it. And many of you, if you haven't seen it, there was a press release after the 1.6 million doses given. We know now the number of side effects and serious side effects that happen across the country. So we need to lean in technology as well to help select the right outcomes and put them back to the providers and to the research. There's a number of fantastic work being done sort of as well in this realm around concussion and kids, and how do we get them safely back and at the right time back to play or to school with called digital biomarkers. So there's a lot of cool stuff happening, and soon they'll be available, hopefully. But we need to encourage that kind of stuff and that kind of innovation where the patient is at the center of the response of treatment.
Great. Everyone, we only have 5 minutes left, and I want to give time for any parting thoughts from each of the panelists. Starting, Megan, I'm going to start with you. And as you think about parting thoughts for everyone tuning in today or tuning in later, watching this later, give the audience or give us all advice. What advice do you have for innovators moving forward today and in the future to transform the system to one that's more person-focused and economically sustainable? Megan.
Well, first I want to say thank you for doing this and this discussion. I've learned a lot and really appreciated the opportunity to have it. I think what I would say is engage. I know it takes, from a policy perspective, it takes a long time. We're a very large operation here in Washington, and we don't really turn on a dime, but engage and persist and be part of the discussion, because that's how things change. And they do change. Things happen all the time. Laws pass, regulations are issued, things happen. So please don't get discouraged by this notion that they don't, because they really do. And they would be better informed by people who have new, fresh ideas and are doing things in the marketplace, in the healthcare system that bring those ideas to Washington. So please come.
Juan, final thoughts, advice.
Yeah, I would say, to especially to all the innovators out there, be patient, but be resilient. This is a very complex problem in any way we look at it, and we need that persistent. Be relational as well. Don't feel fear to reach out to all the different stakeholders. We have interest in improving the system. Evidence here, we make time to get things out to you. And I look forward to the future. Thank you for having us here. It's been a phenomenal conversation.
Thank you. Lauren, advice.
I too have loved the conversation, so thanks very much for the invite. And I guess my advice would be to think bigger than the immediate problem in front of us. We all are suffering because of a broken healthcare system. Even those getting rich from a broken healthcare system are suffering because of a broken healthcare system. The opportunity cost of sinking 20% of our GDP into healthcare is impacting education, it's impacting, hunger, it's impacting transportation, it's impacting the infrastructure that we're driving across every single day. We really have to recognize as a country and as a society that we need to come together and think bigger than our broken arm or our job to, get open enrollment materials out, or our patients' interest in having the most recently released drug sitting in front of us. We need to think bigger than all of that and think about collectively how we can work together.
Thank you. Marianne, advice?
Just simply, again, to repeat myself, this is an era of transformation like I've never seen in my entire career, nor will I ever see again. And we will not save our way. We will not regulate our way out of this mess. We will innovate our way out of the mess. So the possible silver lining of this terrible pandemic is that we have broken the health system and we get to kind of rebuild it. And it can't be like it was, because that didn't work. So this transformation is in my mind a wonderful thing.
Christine, I want to make sure you have the final word as we close out today's session. From a patient perspective, what advice do you have for those tuning in?
Sure. Value the voice of the patient. Create policy that regulates, but also ensures that patients have access to healthcare, and invest in communities that are disenfranchised.
Thank you all again for joining us for this incredibly important conversation and having a real honest and open discussion about the healthcare system. For those of you tuning in, please stay engaged with Cambia Grow. We continue these conversations throughout the year. We have a great discussion currently virtually through our Cambia Growth membership, and once we're back in person, we're very much looking forward to seeing everyone in person as we continue to convene, identify, and catalyze solutions to create a better healthcare system. With that, one last thank you, and happy 2021. Continue these great conversations. Bye now.